Uh, Very good afternoon, friends. I welcome you to the webinar series sponsored by Clinical Infectious Disease Society, CIDS. And this is the second webinar series. We are in the second lecture of the second webinar series. And this is going to be real life case scenarios where the presenter will be Dr. Rajiv Karthik, who is an infectious disease physician based at Christian Medical College, Vellore. And then we have three eminent panelists, Mr. Dr. Arvind, who is the HOD of Infectious Diseases at Trivandrum Medical College. And I know that all of us are aware Kerala was the initial hotspot, and they have handled the situation very, very well. And there is a famous Kerala model in containing the disease. And probably Dr. Arvind was a very key person in the state of Kerala in handling the pandemic. And we would have many things to learn from him. And then we have Dr. Vasant Nagwekar, who is a senior consultant physician and ID physician based at Mumbai. And he has been in the management or treatment front of many of these patients with COVID. And he practices Lilavati Hospital and Global Hospitals Mumbai. A seasoned man with a lot of experience in managing critically ill sick patients. And we have Dr. Bharat Purandare joining us from Pune, and he is one of those earliest batch of ID physicians to be trained from Hinduja Hospital, Mumbai. And again, man respected for his wisdom and clinical expertise, and he is again in the middle of the COVID battle. So the the three panelists are handling patients with COVID on a daily basis. They've got a lot of experience and expertise in managing such patients. Then we have Dr. Rajiv Karthik from CMC Vellore, and he is a DM in infectious diseases. And that's something new to this country, to have DM in infectious diseases. Generally, you have DM in cardiology, nephrology, something like that. And Rajiv is a DM in infectious diseases from CMC Vellore, and he has a Master of Public Health also, and he had fellowship done at Tufts University, Boston also. So again, we are looking forward to Rajiv. And please, Rajiv, you could start your session. Please go ahead.
Good afternoon, everybody. Am I audible?
Yeah, please go ahead.
Okay. Good afternoon, everyone, and welcome to this afternoon's webinar on COVID-19. Over the last weeks, we've had several lectures by several eminent people on various topics on COVID-19, ranging from epidemiology, diagnosis, infection control, and management. So now we changed track slightly, and we're going to look at how we manage COVID-19. We're going to do it as a case-based approach, and we have three panelists who are eager to discuss and share with all of you what they have seen over the past few weeks. Dr. Nambi has already introduced them, Dr. Arvind, Dr. Bharat, and Dr. Vasant. So what I will be doing is I will present a few cases, and then we'll get the panel to discuss issues around these cases, and then we'll move on to the next case. We will keep questions for the end, and we can take your questions at the end of the session, and we can have a meaningful discussion at that point in time. So with that introduction, I would like to get into the first case. Next, please. So these are the things we would like to discuss today: early clinical recognition, diagnosis, treatment options, and management of contacts. Next, please. So without further ado, let's get into the first case. So this is a 53-year-old male who is a shopkeeper. He presented with fever with myalgia for 2 days duration, and he had temperatures up to 102 degrees Fahrenheit, dry cough for a day. However, there was no sore throat, rhinorrhea, diarrhea, or dyspnea. He was a hypertensive, well controlled on AC inhibitors. He had no other comorbidities or addictions, and he did not have any travel history that was significant. Neither was he from a hotspot or a containment zone. Next. On exam, his temperature, he had a temperature of 100.6 degrees Fahrenheit. Little tachycardic, heart rate was 108 per minute. Blood pressure was stable at 130/80 and a saturation of 99% on room air. And a systemic examination was essentially unremarkable. Next. So what I would like to ask the panelists, and I think I will throw this out to Dr. Arvind, is how do we differentiate COVID-19 from other causes of acute undifferentiated febrile illness? Do we test everybody with fever who comes to our outpatient clinic or our OPDs? What sort of workup do we need to do in terms of lab investigations and radiology? So these are the 4 things that we would like to discuss. And I will leave it to Dr. Arvind to discuss now.
Good evening. First, I'd like to thank SIDS for this opportunity. So going to this case, this is actually a very interesting problem because as we all know that this COVID-19, none of the clinical features or majority of the lab investigations may not differentiate this COVID-19 from an acute undifferentiated febrile illness as in this case. The most important clue would have been an epidemiological link. So we need to actually look at this case in 2 ways. There are states in India where there is no community transmission. For example, in Kerala, we don't have a community transmission. So from the Kerala perspective, if the patient is not from a hotspot, we'll just consider this patient as an influenza-like illness and probably category B because the patient is a hypertensive. So whereas if the patient is coming from a community, an area with community transmission, situation may be a bit different, but still this mentioned that the patient is not from a containment zone, nothing like that. But in the coming weeks, this is going to be a major problem because majority of these places are getting the monsoon showers. We are started getting cases like dengue, scrub typhus, leptospirosis, and certain areas, malaria, entry fever, all those things. So it is not actually easy to differentiate between COVID-19 and the other respiratory pathogens like H1N1 or H3N2 or parainfluenza, rhinovirus, adenovirus, etc. So there may be certain clues, like for example, in COVID-19, the build-up of symptoms. So if you are symptomatic, so majority of them may be asymptomatic. In Kerala scenario, 30% are asymptomatic, and maybe 80% have mild symptoms, and severe infection is in only around 10%, and critical illness in around 3%. So the build-up of symptoms in COVID-19 in the first week is not as dramatic as in case of a dengue or say in case of an influenza. Only when the patient is having dyspnea, we tend to notice that the patient is having SARI, and that becomes an indication. So in this case also, if there is no epidemiological link, we want to test the indication maybe SARI, but from the clinical history, it does not look like a SARI, it is an influenza-like illness. So whether to test this or not to test. So from the lab investigations, the clue may be a lymphocytopenia. So majority of the tropical fever syndromes, like say dengue, is not having a lymphocytopenia to begin with. So that may be a clue. And one advantage with dengue is that you can do the antigen-based testing. And for malaria, you can consider the rapid malaria test. And for entry fever, you can have the typhoid or IgM. But unfortunately, for COVID-19, we don't have an antigen-based test, and we need to rely on RT-PCR, whose sensitivity is not more than 70%. So to test or not to test. So in this case, patient, since the patient is not coming from a containment zone and since there is no epidemiological link, we may not test. If the patient is coming from an area with community transmission, then COVID can present in any way. Any patient with any respiratory symptoms, any GIT-like symptoms, any cardiac involvement, or any fever without a cause, in a patient is coming from an area with community transmission, we can consider a testing. But in this case, it may not be warranted since the patient is not coming from a containment zone. Now coming to the workup of this patient, since the patient is having a fever of 1 or 2 degrees Celsius and happens to be a hypertensive and patient is like having influenza-like illness, so we can go out with your usual lab workup can be done. And if you are doing a throat swab to rule out another respiratory pathogen like H1N1, we need to keep one thing in mind, because there is a chance of a co-infection with influenza, or even in COVID suspect, there is a possibility of an influenza co-infection in patients in areas with community transmission. Just an influenza positivity does not rule out COVID-19 infection. Now coming to the radiology in this case, if the clinical features are suggestive of say an ILA progressing to SARI, then only the X-ray test is indicated. Okay.
Raju, you require to unmute.
So, couple of things that I would like to point out through this case. One is we should not forget other causes of acute undifferentiated febrile illness. So, sepsis, bacteremias, malaria, and once the rainy season starts, we'll start seeing other causes of acute febrile illness like dengue. So I do know that we are in a pandemic and COVID-19 can actually present in any way. But the point to learn here is that do not forget other causes of acute undifferentiated febrile illness. And workup should reflect, looking for these causes in terms of blood cultures, malarial smears, rapid tests for and rapid tests for dengue. To test or not to test, there are certain guidelines which mandate, how we go about testing. Testing is not universally available, and it's there are guidelines by the Ministry of Health and Foreign Affairs of Indian government, which tells us who to test and what not to test. Over the last few weeks, definitely there has been a relaxation in the kind of patients that we can test, and now the criteria is fever / upper respiratory infections, suspect COVID, can do the test. So testing was very restricted in the initial days, but as time has gone on, the testing guidelines have been restricted. So with that, we'll move on to the second case. Next. So this is a 43-year-old male. He had fever for 4 days duration. It is moderate to high grade and dry cough for 3 days. No upper respiratory symptoms, cough, diarrhea, or sore throat. And he had worsening breathlessness for 1 day, and hence he was referred to our hospital. Next. He was a newly diagnosed diabetic on oral hypoglycemic agents. Sugars were well controlled. No other comorbidities. He did have some history of contact with returnees from the Delhi meet 10 days prior to the onset of his illness. So on exam, his respiratory rate was 36 per minute. His blood pressure was 110/70. Heart rate was 118 per minute. And oxygen saturation on room air was 92%. He had a temperature of 100 degrees Fahrenheit, and he was fully conscious and oriented. And his respiratory system exam revealed some bibasal scattered crepitations. Next. So this is his initial chest X-ray that was done. Next. And this is the X-ray that was done after 24 hours after he became breathless. Next. So I'll ask Dr. Vasant to discuss this. And basically, this patient was diagnosed with severe acute respiratory infection, or SARI. He was admitted into the ward, but within 12 hours, he developed worsening symptoms and shifted to the ICU. Next. So what I want Dr. Vasant to discuss is that patients who are moderately sick, as evidenced by his clinical condition on examination, are there any markers of disease severity that we can use? How do we decide between whether this patient goes to the ward or whether he goes to the ICU? And what sort of prognostic tools do we have at the time of admission to say, what is the prognosis of this patient?
Right, Raju. So I think it's very clear that this patient has a risk factor for, getting a COVID-19, because he's come from Delhi, and then even if he wouldn't have come from Delhi, the history in this pandemic, having fever going on for 4 days and dry cough and then breathlessness, I think any patient having this symptom would definitely qualify for a COVID-19 suspect. And on top of that, he's got comorbid conditions. He's a diabetic also. And when he came to the triage or whichever hospital, he already was having a respiratory rate of 36. His pulse rate was 108 or 110. And saturation at room air was 92%. So I think definitely he falls into the category of moderate or moderate to severe illness, because the X-ray, even if it is normal, because X-rays will not really pick up, shadows, what a CT scan would pick up here. So definitely this patient, I would keep him in the intensive care unit and not keep him in the ward, because he is already having a respiratory distress. He is already desaturated to 92 at room air, and in no time, as like you said, that he was in the ward and had to be shifted to the intensive care unit. So I would have referred to keep him in the intensive care unit and observe him. Now, the second thing is that how do you prognosticate a patient at the time of admission? So in our hospital, what we follow is the NEWS score. We follow the NEWS score, which talks about the pulse, the saturation, the blood pressure, and the alertness of the patient. And also we have added comorbid conditions and the age criteria of more than 55. I think any person who's got a NEWS score more than 6, that is whatever, I think according to points, I think it hardly takes 30 seconds to calculate the NEWS score once you have the blood pulse, BP, saturation, to know where the patient should be going. I think anybody having a NEWS score of more than 6, that is what we follow. The new he qualifies to go to the intensive care unit. And also, I think if the X-rays normal, I think there are many reports where they say ki you do a CT scan that only once your patient is not doing well or once is deteriorating. I'm of the other opinion that if you have once you shifted the patient to the intensive care unit, I don't think we should be reshifting the patient to the CT scan for repeating a CT scan. Because shifting the patient down will cause a lot of a lot of people coming in contact with that. So here, before what I would have done is with the X-ray normal research, I would quickly do a CT scan and shift him to the intensive care unit, which is COVID ICU. Also, simultaneously in our triage itself, we have something called as mini fever panel, so which we get the reports within 30 minutes. So by the time the CT everything is done, and even if before the patient is shifted to the intensive care unit, we have something called a CBC, CRP, LDH, and an X-ray chest, what is being done, which gives us a fairly idea, as Dr. Arvind has already described, that looking for lymphopenia. And I think lymphopenia, there also the neutrophil to lymphocyte ratio also tells you the prognosticating factor key, how this patient is going to behave. I think if the age is more than 50 and if you're neutrophil and already diabetic, and if your neutrophil to lymphocyte ratio is more than 3.13, according to one of the studies, definitely shows that the patient his prognosis will be guarded at this stage. So this is how I would presently shift the patient to the ICU, put him on a high flow nasal oxygen, or even at least 4 to 6 liters of oxygen, and see how he is behaving. And I think the treatment part we will be discussing separately. So this is how I would approach this patient.
Thank you, Dr. Vasant, for that discussion. Yes, so basically, there are few things that have been used to actually predict severity of illness of patients and who will actually, become sick and who will deteriorate. And I think you elaborated on several of them. And one of them is actually the neutrophil lymphocyte ratio of more than 3.13. Anybody with the age of more than 50 and NLR of more than 3.13 has shown to have a worse prognosis. And again, lymphopenia is one of the risk factors. And one of the Chinese studies actually showed that degree of involvement on CT scan, if there is more than 50% involvement of the lung fields on the initial CT done, they also have a worse prognosis. But yes, I agree with you. In hindsight, it probably would have been wiser to shift the patient to ICU directly. Yes, there are some logistical issues of getting CT scans done for everybody in terms of, cost, infection control. We may need a dedicated CT scanner for COVID patients. So logistic issues are definitely there in getting CT scans done. May not be possible everywhere, but yes, definitely chest X-rays are not the best, and many times early disease can be missed on the chest X-ray. So we'll go on to the next.
I wanted to add a few more things that,
sure.
Of course, once he goes to the intensive care unit, or even before, I think the triage itself, we do a arterial blood gas, so which also tells you the PO2 and what is the PCO2 of this patient. Apart from that, I think once he moves into the intensive care unit, we have a panel, we have a standard panel, which where we do I think not every hospital would have that. So we do a D-dimer, we do an LDH, we do an interleukin 6. I think this also tells us and a serial subsequently, next every 48 hours, if you do this, a ferritin, which also, it tells us also the prognosis and how this patient is going to behave. So I think IL-6, we are lucky that we are having this facility, but not every hospital would have this So I would say that D-dimer, LDH, your liver enzymes, creatinine, because I think this virus is also can present with an acute renal failure at times.
Yes, definitely other markers that we can use once the patient is admitted, ferritin and D-dimer, usually available in most inpatient facilities. But I think, as you mentioned, IL-6 is not commonly available. I think at least in most hospitals is not commonly available as a diagnostic tool. Yes, but totally agree with you in terms of all these markers being used as prognosticating tools for somebody who is moderately to severely sick. So we'll go on to the next case, and I'll request Dr. Bharat to discuss this. This is a 46-year-old male, a fruit seller, who was unwell for 7 days with fevers and cough and worsened for a day and came in with worsening breathlessness. Again, no travel history, no comorbidities. He had been to a couple of smaller hospitals with similar complaints a few days earlier. He was advised home quarantine and had also had in the chest X-ray, which was normal. Next. On examination, his saturation on room air was 70%. His blood pressure was 100 by 60 millimeters of mercury. Respiratory rate was 50, and his heart rate was 170. His GCS was 13 by 15, or he had no focal deficits, and his rest of his examination was unremarkable. Next. This was his initial chest X-ray that that was taken, and you can typically see the bilateral, interstitial, peripheral sort of infiltrates that are seen on this chest X-ray. Next. And these are some screenshots of his CT scan. It does show this typical bilateral subpleural ground glassing opacities with some amount of consolidation. So he was admitted into the ICU straight away. He was ventilated, and he was being managed as a COVID suspect with severe acute respiratory infection. So he was tested at the time of admission, which was 7 days into his illness, and he was tested 2 days later again, and he was also negative. Next. So, Dr. Bharat, the things that we would like to discuss here is that what is the role of chest imaging in the diagnosis of COVID-19 pneumonia? Does everybody need a CT scan? And do we need to repeat CT scans? Does it have prognostication effects? Secondly, you have somebody with a clinically compatible illness, but repeatedly the tests come back as negative. So what do we do? And what samples should we send? Should we change the samples that we send? Are there any other diagnostic tests or any other tools that we can use to confirm this diagnosis?
Okay, thank you, Rajiv. It's a very, very excellent case, and I mean really intriguing case. See here, all the reports have to be interpreted in light of the epidemic situation surrounding your circumstances. So if you are in a hotspot where a lot of COVID cases are coming to you, and a patient occasionally comes negative, it becomes a really very, very difficult thing to believe that whether the patient is really negative or not, because the negative predictive value of the test will go down if the pretest probability of the test is more. So if you've got a very bad epidemic going around, and if you are getting a lot of COVID patients from the surrounding community, then I think such a kind of presentation, bilateral ground glass opacities, very bad hypoxia, and there is really nothing else to explain this particular scenario. I would really think that this still can be COVID, but somehow we are missing the RT-PCR. So then we'll have to go into the nitty-gritties of the thing, how the sample was collected. So if the patient is like very dyspneic, you told that the respiratory rate is 50, it would have been pretty difficult to get a oropharyngeal or even nasopharyngeal sample for such a difficult patient. And we know that their sensitivity is limited. For nasopharyngeal swab, it is around 65-70%. For oropharyngeal, it is around 35-40%. So we are missing 1 out of 3 cases, even with proper sampling in a stable patient. here we have got an unstable patient. He may not have cooperated for a sample. Now, once we intubate him, it's likely that we get a lower respiratory sample. So if it is possible to get an endotracheal aspirate, I would definitely prefer that sample for RT-PCR as compared to the upper respiratory sample, because it has got more sensitivity to pick up the disease. Now, this patient was 7 days into the illness, and we all know that the PCR sensitivity really goes down when we cross 7, 8, 9, 10 days. And that's why maybe we are missing the diagnosis in this particular case. Now we have got this rapid antibody test available, but it's not yet available for clinical use. It has been made available only for epidemiologic purpose. So if at all we get an access to a rapid antibody test, day 10, day 11 into the illness for a patient who's intubated, very badly hypoxic, RT-PCR is coming negative, definitely I can think of this rapid antibody test for COVID, whether it can help us. Then, the PCR can also be sent through blood. PCR can also be sent through stool samples. However, we have not tried here in our setup to send such samples to get a PCR done, because we really don't know what kind of rate of positivity these samples have. The best sample would be lower respiratory in this particular case. And then, in addition to going for diagnosis of COVID, we'll have to find out whether we are missing any other cause other than COVID for this particular presentation. So this patient has hypoxia, bilateral ground glass, everything fitting into COVID, but similar presentation can also come in an HIV positive patient with PCP. You can also get this kind of presentation when somebody is having a rickettsial infection with ARDS or some kind of hypersensitivity pneumonias. If that patient has got some bacteremia leading to acute lung injury, this kind of presentation can come. So, if we are missing any other cause other than COVID, also that side by side also that workup should be set. Now, this patient's prognosis you talked about, prognosis is really going to be very guarded about this patient, because probably he will get intubated right in the ER or probably, and when they get intubated and if he is COVID positive, the mortality is in excess of 60 to 70%, definitely mortality is in excess. So prognosis of this patient is as it is going to be bad. And in event of a negative RT-PCR, I believe we'll have to search for other causes which can cause a similar illness. If we get a hold of an rapid antibody test, one can consider that. And all other tests, like for example, say LDH, procalcitonin, ferritin, or even interleukin-6 for that matter, D-dimer, all of these tests will help only when your COVID comes positive. Then they will have their own importance that you can interpret. In an absence of a COVID test, I don't know how to interpret interleukin-6 level. I don't know how to interpret high D-dimer or something. So, for this particular patient, there's got 2 successive negative tests. It's really a difficult scenario. But if I'm getting, say, so I will ask what are my positive tests over last 1 month. So if over last 1 month, if I've sent 100 tests and more than 50 have come positive out of those 100, there is a good chance that this patient still has COVID, but somehow we are missing it. But if my positivity rate is say less than 50%, 10, 20% or something like that, then I think I will also search for other causes which can cause a similar presentation.
Thank you, Dr. Bharat. Yes, so the points that we want to take away from this are: one, think broader. Yes, in a pandemic situation, COVID-19 is something that we should first think of, but we shouldn't forget the rest of the disease conditions that can present in a similar way, as you so clearly elucidated. We can't be missing scrub typhus or PCP or hypersensitivity pneumonitis and such things. So think broader. The second thing is that the sample that was actually sent. So nasopharyngeal samples, we know after day 7, their sensitivity is much lower. And actually this patient had a BAL that was actually positive on a third test, because the clinical suspicion was so high. So basically, if your clinical suspicion is there, there are problems with the sampling and the testing. So yes, try and get a lower respiratory sample if possible. That's a point to take home. What do we know about antibody tests? I think we don't know how antibody tests will help us additionally, and what to make of it. It's still not available to any of us to use, but that's something to keep in mind when they're available, how to use them, especially to aid in the diagnosis. So we'll move on to the next case. So this is a 49-year-old male who was recently returned from London, and he's diabetic, hypertensive, and obstructive sleep apnea on home CPAP. He was admitted with very mild disease. He tested positive. He had very mild disease. He was treated in the ward, did not require to go to the ICU. He got some hydroxychloroquine and azithromycin for 5 days, supportive care. He clinically improved and became asymptomatic by day 5. Next. So what we saw was that this graph actually shows us the different points at which his test was done. And it, on the x-axis actually plots his cyclical threshold for the RT-PCR. And it actually shows that after the initial point where he was tested, there was a drop in the viral load, which means the cyclical threshold went up. And then slowly it started actually coming down, indicating that there might be an increase in the viral load. Next. So this is a phenomenon I think many of us would have seen, where the patient has clinically improved, but the RT-PCR remains persistently positive. So from the first test that was sent on 26th March, he is still persistently positive for almost a month. And I'm sure many of you in your practice would have seen the same thing. So what does this mean when patients have persistently positive RT-PCR? They're absolutely well, they're clinically recovered. What does it mean? And what sort of, can we use this as a discharge criteria for patients? We know that world over, the criteria for discharge is 2 RT-PCRs negative and clinically well. But it looks like there are some patients who are persistently positive and they cannot be sent home. They're still in the hospital, but they are well. So what can we do in this situation? Is antibody test the answer? Is there some other thing on the horizon? And I would ask Dr. Arvind if he can sort of discuss this.
Actually, this sort of scenario has become pretty common now in Kerala. In around 3 to 5% of the cases, this persistent viral shedding, I won't call it viral shedding, it is persistent shedding of the RNA, nucleic acid, because we are not very sure because the viable virus is there or not. As of now, we have around 30 patients who are continuing to be persistent shedders for more than 20 days. And yesterday, one patient got discharged on day 48, and that patient was totally asymptomatic for the last 45 days. So this is what is happening. As you rightly mentioned, majority of the discharge policies across the world, right from CDC, ECDC, WHO, Singapore, everyone, do mention about the clinical clearance and radiology resolution if it was indicated in the beginning, along with 2 RT-PCR negativity 24 hours apart. So this persistent viral shedding does have policy implications as well. Now let us look whether this persistent shedding of the ribonucleic acid can be equated with infectivity. This is the major concern. Majority of the treating doctors are concerned if the patient is going on shedding the virus for more than 30 days, is the patient still infective? So as of now, we need to rely on the literature from the other parts of the country, because we are not had never done a viral culture in this setting in India. So what they say is the paper which came in Nature by Roma and Hostel. So even though this persistent viral shedding can be prolonged as long as 63 days, the chance of isolating a viable virus in culture is not there after 8 days. And recently in the Journal of Infection, there was a case report from Taiwan where they could isolate the virus in tissue culture as long as 18 days. So what we know is that basically this persistent viral shedding cannot be equated with shedding of the viable virus. So what is being shed is actually the parts of the ribonucleic acid which is not viable, so it cannot be equated with infectivity. So this is pretty important. Then how can we prove? So this is the question we are getting from the ground level. How can we prove that this the RT-PCR positivity cannot be equated with infectivity? For that, we have to resort to 3 methods. One is to go by a viral culture, which actually in India can be done only in a BSL-3 facility, which happens to be, for the Mumbaikers, it's very easy. It's in NIV Pune. For us, it's a bit difficult. The second is if you're having a validated, very good quality IgG test, if you're having an IgG positivity and patient is clinically stable, then probably we can use it as a marker of, say, convalescence and consider discharge of the patient. And third one is having a look at the subgenomic mRNA levels, which is not being done in India. But this phenomena of persistent ribonucleic acid shedding is not unique to COVID-19. This has been demonstrated in SARS-CoV-1. It has been demonstrated in MERS. It has been demonstrated in polio. It has been demonstrated in adenovirus, and it has been demonstrated in influenza as well. So the next question is whether the shedding is more commonly, persistent shedding is more commonly seen in the symptomatics or the critically ill, or whether the asymptomatics will shed as well. Even though there is literature to show that this persistent virus shedding is more commonly seen in the severely infected or in those who are immunocompromised. But then our experience in Kerala suggests otherwise. Shedding is actually common in both arms, in the severely ill as well as even in asymptomatic patients who are tested positive. They are also having the same extent of persistent viral shedding. Now coming to the policy implications. So majority of the patients have to be kept in hospital, and they can be discharged only when 2 consecutive RT-PCRs are negative. And then if you are going on aggressively testing to demonstrate this RT-PCR negativity, so it's a huge loss of money to the exchequer, because in the government settings in Kerala, all the cases are being managed by the government hospitals only. So for that, a lady who was discharged on day 48, we had to do around 20 RT-PCRs. One will cost around 4,000 rupees. That is one thing. Second is the PP. For one patient, we require around 10 PP. Then the psychosocial aspect of the patient as well as the treating doctor. This is also very important. An asymptomatic patient who is kept in hospital for more than 20 days, they require psychological counseling. All these issues need sorting out. And then means probably we have to rethink our discharge policy, because this is becoming more of a reality. So practically, if the patient is fever-free for more than 3 days, if there is clinical and radiological resolution, the chance of the patient being infected for more than 10 days from symptom onset is going to be remote, despite a persistent RT-PCR positivity.
Thank you, Dr. Arvind. I think this is a thing that is being recognized world over, but at the current point, we don't really have clarity if the discharge criteria would change for patients. And looking at different countries' discharge policy, the one criteria that is the same is 2 negative RT-PCRs and clinical resolution. So it looks like for the time being, we don't have great clarity on whether this will change in the near future, and whether antibody tests will help us or will enable things to become different. So we'll move on. Next case.
Raju, I had a comment to make. So in case if you are able to get 2 negative RT-PCRs, well and good. But as Arvind said, we have actually proposed to government of Maharashtra that if the patient is absolutely clinically asymptomatic for more than 5 days, I think what Arvind is saying 3 days, yes, that is holds true according to the CDC and even the British College of Pathologists, whatever they said. But here, if the beyond 14 days, if the patient's is clinically completely asymptomatic 5 days, we have said that if home quarantine is possible, that if the space is there, good. Otherwise, we move the patient to COVID care center. This is what we have proposed, because he's blocking the bed unnecessarily, and psychologically also, as Arvind clearly said, that it's causing an issue.
Totally agree with you, Vasant. Thank you for that. We'll just move on. So next few cases, we'll discuss about treatment. And this is an area which keeps changing almost every couple of days. One day you hear of a miracle drug, the next day it no longer is shown to have value. So we'll go ahead. Next, please. So we'll go back to our case 1, and I'll ask Vasant to discuss the first 2 cases. Somebody with mild disease who really does not need hospitalization, with no significant risk factors. For some reason, he's being tested and he's positive. Would you treat? If so, with what? And how will you go about it?
So, Rajiv, I think this patient had definitely, as you said, it's a mild disease. He doesn't have any comorbid conditions also. And possibly, since it's come positive, first thing is definitely he requires to be isolated. So he will be isolated either in a COVID care center or maybe in the hospital. So either of it, if you have a bed, you can hospitalize him. But he requires definitely isolated from the community and from his family members. That's very important. Now coming to the treatment part, it's controversial because if you see every state has got a different policy. Either mild disease you can treat, leave them alone, not treat them and treat symptomatically, or at the most you can give hydroxychloroquine as a first line treatment and nothing, no other medication. So either you can leave them alone or you have an option of just giving hydroxychloroquine. I think this state-wise it keeps varying from hospital to hospital. So I think, does he need hospitalization? If you ask me, no. He will be occupying a bed. Possibly what he requires is isolation, and he can be isolated in a place like COVID care center, where like in Mumbai we have a lot of COVID care centers where there's a doctor who comes and just examines all the patients in once a day and sees all the parameters are normal. So I think he doesn't occupy a bed. And so no, he doesn't have any significant risk factors as such. So I would say there's just isolate him and either treat symptomatically, keep a close watch on him, because even if you do not have comorbidities, still there will be some number, a small population of patients who would progress to moderate or moderate stage. So even if it's kept in the COVID care center, he requires to be kept vigilant. So that is what is more important here. So apart from the simple paracetamol, zinc and whatever, I think all these supplements can be given. But no antiviral drug, because I don't think we have a definitive antiviral drug as of now.
Okay, we'll move to the second case. And Vasant, I'd like you to discuss this as well. This is somebody with moderate disease, like we discussed, in the second patient. Doesn't really require ICU care, but requires to be admitted in the ward. He has one or more than one risk factors. How would you treat him? And do you just want to elucidate a little bit about, the drugs that available and the sort of evidence we have for using these drugs?
Okay, so this second case is a case because he was a diabetic, and then he had a lower side saturation, he had tachycardia, and definitely he required, of course, he was in the ward, and you can keep him in the COVID ward where, close monitoring can be kept. So this patient does not qualify to go to the COVID care center, but he definitely requires to be hospitalized or a dedicated COVID health center, whatever you want to say, but he requires to be hospitalized and in a place where possibly intensive care facilities available, as you already said. Now, he's got definitely multiple risk factors, and the treatment here, one is definitely, we would like to prove that whether he's got COVID-19 or not. So if your first nasopharyngeal swab is negative, we will repeat another nasopharyngeal swab, and also look for that we don't miss other tropical diseases or other common, in case you're, because when we have a mini fever panel, we have the CBC, LDH, SGOT, AGPT, NS1 antigen, MP smear, so that we don't, what has been discussed by Bharat and Arvind earlier, that we don't miss other tropical diseases as well. So I think once we have the COVID-19 positive for this patient, then definitely I would put him on hydroxychloroquine plus an azithromycin as of now, because I think there is varying data on this, because initially there was a paper which said that hydroxychloroquine plus azithromycin seems to be promising. Then a lot of papers saying that hydroxychloroquine versus placebo doesn't have much data. But there was one paper which came from France, which discussed about 1,060 patients who received hydroxychloroquine plus azithromycin, and it showed that the cure rate was 91 or 94%. But the drawback of this paper was that as 85% of the patients otherwise would also get better. So there was no comparative arm for this paper to say that what would have happened to those people, 1,000 other patients, suppose if you wouldn't have given hydroxychloroquine plus azithromycin. So as of now, since we do not have any drugs, we know that this hydroxychloroquine, for whatever worth it is, has some anti-inflammatory or immunomodulatory activity. We use this, and plus azithromycin. So there are other antiviral drugs which are being spoken about. One is the lopinavir, ritonavir, but I think it's ICMR and even the New England Journal of Medicine paper, which clearly showed that whether you use lopinavir, ritonavir, or whether it's a placebo, those who did not receive lopinavir, ritonavir, in both the arms, the clinical outcome was the same. So I think lopinavir, ritonavir again is as good as a placebo as of now. Next, I think we were very hopeful in US that remdesivir was a very, very promising drug. But of late, I think last 2 days, we are receiving data that remdesivir also is a failure. But here, I think in this US, the arm, I think they use remdesivir in the later part, I think beyond 7 days. Maybe we don't know if you use it early, whether the clinical outcome would change. But as of now, I think remdesivir also seems to be borderline. Then the third drug is favipiravir, which again there is no data or no solid data on this. The third also favipiravir drug. So these are the three different antivirals which qualify. But I think so as of now in India we don't have remdesivir, neither favipiravir. So I think in this case it would be hydroxychloroquine plus azithromycin. In case he goes to the intensive care unit and requiring oxygen support, then possibly I would use plus minus lopinavir. Then the question also comes about, since if he gets desaturated, possibly whether to use steroids or not. I think we can.
Vasant, shall we just discuss that in the next case?
Yeah, okay, fine.
Okay. So just to summarize, whole lot of antivirals that have shown to be promising, but real world data actually shows that, they may not be as good as it promised. A lot of talk about hydroxychloroquine. But again, recent data coming in, especially from France, shows that it may not be much better than standard supportive care. So what's the space? And I think as time goes on, we will get more and more information about what exactly, is the effect of these drugs. Just a note, if you're using hydroxychloroquine and azithromycin, please pay attention to the ECG and the QTC, because both of these prolong QTC. So it will need, very close monitoring. So we'll go on to the third case, and I'll ask Dr. Bharat to discuss this. So this is a 52-year-old lady with fever, cough for 3 days, breathlessness for a day, hypertensive on medications, no other comorbidities, and no travel history. Next. So she comes in quite sick, the respiratory rate at 42 per minute, pulse rate of 128, saturation only 40% on room air. She gets intubated immediately in the emergency room. Next. And this is what her chest X-ray looks like. So very, very florid abnormalities on the chest X-ray. And somebody who's very unwell goes to the ICU straight away. So what would be the medications that we would use in such a sick patient? What is the role of steroids and other immunomodulators, interleukin-6 inhibitors? Is there any benefit in giving them? So Dr. Bharat, would you like to discuss this?
Yes, see, now what? There are many points to discuss in this case. Now this patient is already in a very bad and florid ARDS. So here actually the disease has progressed to such an extent that at this point of time, I doubt whether whatever available therapies we have, whether it is HCQS, azithromycin, steroids, tocilizumab, or even if from a trial or something we bring the 2-3 antivirals, whether they will work at this situation or not, I think very difficult. It's already progressed to a very bad extent, and maybe everything or anything given, the outcome may not change at this point. But 2 to 3 days prior to this presentation, when she was like hypoxic, and then she was requiring maybe 6-8 liters of oxygen and not that bad. There was a place where we could have used steroids or we could have used tocilizumab. So I can tell you that first of all, I would like to mention one point, I think, which is important to be discussed for all the audience, is that we are going to give hydroxychloroquine to most of our patients, including this particular patient. Now this hydroxychloroquine cannot be given in certain situations, and we have to understand those situations before we start giving it right, left and center. One thing is that somebody who's already allergic, or that is very common knowledge, that somebody who's got hypersensitive to chloroquine or its products, one should not give it. Somebody who's got already having a retinopathy or a maculopathy, we should not give it. Somebody who's got G6PD deficient, we should not give it. Somebody has got porphyria or a recent myocardial infarction, or as we have discussed, a QTC which is already prolonged more than 450 or 500 milliseconds, we should definitely be very cautious, or rather avoid hydroxychloroquine. And then in diabetic patients, because diabetes is a good subset of these people have got diabetes, risk of hypoglycemia one has to always consider, because we know that hydroxychloroquine has now been recently approved as a drug for treatment for diabetes, because it prevents the destruction of insulin. and that's how it can cause hypoglycemia in sick patients. So these 2-3 things first we should keep in mind while prescribing or not prescribing hydroxychloroquine. Now coming back to this our patient, so as I told you, it is already a very progress case. So if she would have come 2 to 3 days before this, when the bilateral opacity started, when the oxygen requirement starts increasing, I will definitely think about steroids and tocilizumab. Now if you ask me the evidence is really weak for both these products. For actually steroids, there is a conflicting evidence whether steroids are useful or whether steroids are detrimental. But one thing we know for sure that a part of the disease is because of the virus itself, viral induced lung damage. And second part is the inflammatory response which comes from the body to the virus. And therefore, if we try to measure the inflammatory response to the virus, then one can definitely think whether steroids can be of use in this particular patient. So if this patient has a very high CRP, if this patient has an elevated LDH or ASR, if this patient has elevated uh, uh, ferritin, then definitely I will think that yes, there is something, there is some immune activation, there is some cytokine storm probably starting over here. And to control that cytokine storm, steroids can be given. Now, data is emerging that if steroids are given earlier in these patients before a frank ARDS sets in, it might help some patients. But at the same time, it might even prevent intubations in some patients. It might prevent disease progression in some patients. But at the same time, it can cause, in a particular in our country, where secondary bacterial infections are so rampant, the increase in the risk of secondary bacterial infection can happen. And when we use steroids in patients, these patients, many of them develop also hyperglycemia, which we need to manage very carefully. So I have used for myself steroids in some patients who were hypoxic, leading 2 to 3 liters of oxygen, and who were having elevated inflammatory markers at a dose of 1 milligram per kilogram of methylprednisolone, divided in 2 doses for 5 to 7 days. And what interesting thing I found that some of them have definitely improved. Some of them have gone and got deteriorated and got still intubated. And but if you withdraw the steroids early, some of them can develop a redevelopment of hypoxia and relapse of a disease. So that one thing one should be careful when you withdraw steroids for any particular disease. But then there is no trailing tail of steroids. So means if you give it for 5 to 7 days, after that there is no reduction in steroids. You abruptly stop it after 5 to 7 days. That's what the guidelines say. Coming to the tocilizumab, tocilizumab, as all of us know, it's an interleukin 6 antagonist, and many of these patients with COVID-19 have got interleukin 6 elevation. Normal level is up to 7, and many patients can have levels of 50, 250, and we have seen patients in our setting of levels of more than 500 also. So there are patients who have got very high interleukin 6 levels, and this is one subset which might benefit from giving tocilizumab. But again, it is not a must that your patient should have an interleukin 6 level and then you should go to tocilizumab. It's not must. If your other inflammatory parameters are showing that there is cytokine storm, even without an interleukin 6 level, you might consider tocilizumab. But it's a good idea to have it first and then give it. And we have a test available over here, and our turnaround time is 1 or 2 days. So it comes within the treatment, range, whether we can think about giving tocilizumab. Now, I will choose to give tocilizumab to a patient if certain parameters are met. Like for example, if my patient is not doing well on steroids, if he's requiring more than 6 liters of oxygen, he's having persistent fever and elevated inflammatory parameters, very, very high ferritin, very high CRP. If at all I'm going to get an IL-6 level, it is more than 7, then definitely I'm going to think about giving tocilizumab before this kind of frank ARDS level that X that you are showing right now on the screen. The time is before 2 to 3 days that such a thing develops. And 1 or 2 doses of tocilizumab can be considered. But before giving tocilizumab, one has to ensure that patient doesn't have an ongoing active secondary bacterial infection. So I will have to do a procalcitonin and maybe some cultures before I can say that, okay, this is only viral and there is no secondary bacterial infection. Then the platelet count has to be good. The liver enzymes have to be less than 5 times of the upper limit of normal. So if these parameters are met, and if my inflammatory parameters are high, and if my patient is having high requirement of oxygen, he is on the verge of getting intubated, at that particular time, if you do tocilizumab, it might help in some patient. There was a small trial which showed that tocilizumab reduces the fever and oxygen requirement in some patients with COVID. However, some patients, even after giving tocilizumab, can worsen and go on to ventilator. So one cannot say that this is the only drug or this is a miracle drug. This is one of the therapies to control the inflammatory response. Whether it works or not, one has to use it and see. And more data is going to come about this drug through few trials which are going to yet to come.
Thank you, Dr. Bharat. Do you want to briefly talk about convalescent plasma as well in somebody who's very sick?
See, for last 3 days, we are hearing reports that yes, convalescent plasma is a good option of treatment. And then again, in our country where manpower is not a problem, getting plasma should not be a big issue. But here, one has to be very careful that the plasma should come from a negative donor. So if your patient is shedding a virus for a long time, then he's not an ideal plasma donor. So somebody who has recovered from COVID, somebody who's now RT-PCR negative, and somebody who doesn't have any other bloodborne illnesses and ready to give plasma, one has to get plasma from them and infuse. But this data is very, very early that it might help in certain patients. Till 3 days back, whatever publications I have read about plasma, all of them were equivocal. Somebody said yes, it would work. Somebody said it would not work. But last 1 or 2 days, we are really finding encouraging reports. And in our country, where plasma should not be of there should not be a dearth of plasma in our country because of the high population, and we should be able to actually see whether this helps.
So basically, in somebody who is moderately sick, a trial of steroids or tocilizumab may benefit depending on if there is a evidence of high degree of inflammatory markers. I think still the evidence is unclear. In several places, steroids are being used, and so is tocilizumab. But I don't think we have concrete evidence to say that either of these is a miracle drug. It's a fine balance between reducing the viral load and balancing the inflammatory response. So I think we'll move on. I think this will be we'll be coming to the end
also, Rajiv,
of this discussion.
Rajiv, just wanted to add, what we have found, unlike the H1N1, which was really difficult to ventilate the patients, where it used to. Whereas these patients, the compliance is not a problem in these people, and the oxygenation is a major concern in these patients. So ventilating is more problem because of oxygenation. Otherwise, if you see, they don't require very high PEEPs and all that ventilator setting. So another thing is that another rule was about whether the small vessel thrombosis also maybe playing a role, and small role of anticoagulation in these people who do not improve their oxygenation.
So yesterday we had a very elaborate lecture on the ICU care and the ventilation and the oxygenation and the different types of ARDS scenarios that we see. So we'll move on. Next slide. So I think we're coming to the end, and only 2 more issues to discuss. This is a 27-year-old lady. She's a daughter of a positive patient who was admitted in the ICU. She was pregnant at 37 plus 4 weeks, Gravida 2 Para 1, and the index patient was unwell for 6 days prior to her admission in the ICU. So Dr. Arvind, I'll come back to you. 2 questions. How do we manage contacts? Obviously, if they're symptomatic, it's easy. What do we do if they're asymptomatic? Secondly, just a few words about COVID-19 in pregnancy.
So regarding the COVID-19 in pregnancy, the data shows that the progression of the disease is not actually different between the pregnant population and the non-pregnant population. What disease determines the disease course is going to be the other comorbidities in pregnancy, like say a gestational diabetes or the eclampsia or a fatty liver. All those things are going to cardiac disease, etc. Otherwise, the pregnancy per se is not actually going to alter the course of this COVID-19 infection. So in the first trimester, the hyperthermia, so suppose it is more than 1 or 2 degree, then there is a risk of, let's say, hyperthermia associated risk of neurotube defects or say premature termination of pregnancy, etc. Otherwise, regarding the congenital anomalies and all, it's not a time to have data on that. And regarding the third trimester, even in H1N1, we know that the pulmonary mechanics, etc., is totally because the diaphragm is going up, then the tidal volume, etc., are going to be altered in pregnancy. So this patient also is in the third trimester of pregnancy and probably had contact with her mother during the infective phase, and she is a primary contact, and she is likely to develop the disease. Then what is her disease course going to be? Since she is not having any other comorbidities, then there are three possibilities. She could be having a mild infection or a moderate infection, does not have other risk factors for having a severe infection. Third trimester, any infection, even in pregnancy, even in ILA, will be considered as a category B2 only. So we need to be more careful. And the other aspect is the chance of a vertical transmission. We know that the transplacental spread, there is no definite evidence because the RNemia in the mother's blood is going to be less than 1% only. So we don't expect placental shedding. So the chance of a vertical transmission is actually very, very less in this case.
Just one more question. So somebody who is a primary contact tests negative once. Do we repeat the test a little later, or do we just quarantine them for 14 days?
Actually, the thing is, the primary contact should be in this quarantine for 14 days. And the time when the test is being done is also pretty important. If the patient is becoming symptomatic, definitely the patient can be tested. Otherwise, for all the high-risk asymptomatic primary contacts, we need to do the test between 5 and 14 days. And in Kerala, we do it at 14 days so that we can be sure that the patient is not shedding the virus. Otherwise, there is no indication for testing an asymptomatic primary high-risk contact.
Okay. I think we'll carry on. Next. Yeah, so those are the two things that we wanted to discuss. Next. Yeah, so just a quick case. Dr. Vasant, if you want to just discuss this. Somebody who had returned from Spain with fever, cough, myalgias, headache, and diarrhea, and presented with this sort of rash. Next. Just a brief discussion on what are some of the atypical or unusual presentations we need to keep our eyes and ears open for. We know that most of the time this presents with a lower respiratory tract syndrome, but just to tell our viewers, what are some of the unusual manifestations that we should sort of be on the lookout for?
Yeah, so Rajiv, I think GI, apart from respiratory tract, GI is a very common presentation of COVID-19. So I think in our triage, apart from respiratory tract, we also have kept loose motions, abdominal pain, and even a severe loss of appetite as these suspect COVID if the patient does not have a respiratory tract and has a very close contact, or I think the travel history was some time back, but yes, travel history if there is a travel. So I think the atypical presentations, what would from a GI point of would be, usually they have severe loss of appetite. We have seen cases where patients have fever, low grade, and severe loss of appetite. And when you do a CT scan of these people, of course, the COVID-19 also comes positive. The first, in fact, I had a patient where COVID-19 first sample was negative and the second came positive. And when we did a CT led us to the diagnosis of this patient as COVID-19, who had come with severe loss of appetite, who had a peripheral bilateral small ground glassing, or what we call as crazy paving pattern, or small consolidation. So this patient, that is one presentation. Second presentation, as you mentioned here, this person coming with loose motions. So this is also a very common presentation, and a lot of people with respiratory tract infection also may have GI complaints. So that is a combination, both is also seen. And third, I think there have been cases reported from US where they are presenting with acute hepatitis. Okay, there are a few case reports where they are presented with acute hepatitis. And fourth, I think what you showed in the picture was a rash. I think I would just take this as a mononucleosis syndrome, and apart from COVID-19, I would look in for if there was no drug history, and if there is no itching, and there's no if there's a history of fever with this rash, I would consider mononucleosis syndrome, and I would look at other causes of viral exanthema also in these people. Of course, I think what you showed was a large rashes, so I think measles and would not qualify. But in a pandemic, yes, this until and unless proven, I would consider, if there's a history of fever, would consider that is this COVID-19 presentation also. So there are also, apart from that, I think even patients, we have there are a few cases reports where patients are presenting with neurological manifestations, but they primarily may not be neurological. These people are COVID-19 positive. Another common presentation, what we have seen is acute myocardial patients coming with acute myocardial infarction. So we had at least 2 patients who had come with acute myocardial infarction, thrombolized, and then subsequently, since there was an alarm about cardiovascular manifestations as COVID-19, we tested them and both of them tested positive. We had another patient who came with a congestive cardiac failure, and there was no acute myocardial infarction in this patient, and he had bilateral effusion. Bilateral effusion is not a classical feature on a CT or on an X-ray for COVID-19, but he had a pulmonary edema-like picture. But we just, as a COVID suspect, we admitted him in the COVID ICU, and then when subsequently tested, he tested to be positive. So I think you can have these varied presentations from neurological, cardiac, from hepatology, like you may have this, as well as GI manifestations with loose motions or vomiting or severe loss of appetite. I think these are the various other manifestations what you could see in your clinical practice. I don't know if Arvind or Bharat have seen something different from these.
Actually, this patient, that picture, so we are having now cases of dengue as well. And if the RT-PCR is, initial RT-PCR sensitivity we know is going to be less than 70% at least, turning out to be negative, and if we are not getting any epidemiological link, we're going to be in soup soon. The dengue season is starting.
Correct.
All right, I think that is the end of my cases and presentations.
Thanks, Dr. Rajiv, taking us through all these cases. And thank all the panelists, Dr. Arvind, Dr. Vasant Nagvekar, and Dr. Bharat Purandare for sparing their time. I think there were a few questions, and I tried answering those, but I would have just asked Bharat one question. What is the dose of HCQ? There's been a lot of people, a lot of regimes, and there are questions pertaining to that. Dose of HCQ, and then is there any role for oseltamivir in the treatment? So Bharat, quickly can you add on to that?
Yeah, see, the dose of HCQS was given in the clinical infectious disease article, this March 9, 2020 article. So it says that HCQS should be dosed as 400 milligrams twice daily for first day, and then it has to be dosed as 200 mg twice daily for next 4 days. So it's totally 5 days treatment, and thereafter you stop it. Now there are some people who say that you give it up to 7 or 10 days for people with moderate or severe disease. But this article of clinical infectious disease is just mentioning only 5 days treatment, and we all know that it has got a very, very long half-life. The drug will remain in body at a good level for nearly 1 or 2 weeks. So that's how the dose goes. And just do remember those contraindications that I told you before starting HCQS. And then the next question was oseltamivir. So the question is, if the patient is presenting with an influenza-like illness and you don't have a COVID PCR available, till that time empirically you can start oseltamivir, because we have seen co-infections happening, and we have even seen that patient came as suspect COVID but turned out to be influenza. So we can start it. But as soon as you get a COVID PCR positive, I believe it will be prudent to discontinue oseltamivir, because it is a drug which can cause neuropsychiatric side effects and even arrhythmias. So it becomes a difficult proposition just to keep on continuing it when it has got no action over COVID virus.
Thanks, Dr. Bharat. Arvind, just one question to you. What is that you people did it so differently in Kerala so that you're able to contain the spread there in Kerala, whereas other states are still struggling? Please, a minute, you could answer in a minute, it would be good.
Actually, the virus is the same, the people are the same. So we believe that, we believe in early case detection, and we believe that in the first 1 week is the period where whatever you are throwing at the patient, HCQS or Azthromycin, anything, is going to work only in the first week. So once hypoxia starts, then it's gone. So we believe in early case detection, categorization of the patients. We won't treat the patients at all. Moderate, we start with HCQS and low dose of azithromycin, and we follow the Tisdale score to look at the QT prolongation, etc. We believe that once the patient goes into hypoxia, and if you are starting the drugs late, there is no point. That is what we are doing. And then we are, our contact tracing is very, very strict. For every one proven case, we have around 35 to 70 primary contacts, and we ensure that they are in strict home quarantine. I think that is the only difference between our state and other states.
Yeah, thanks for letting us know. Vasant, only one question to you. There have been a lot of queries on steroids. What is your take? Can you just tell it in a single line? Steroids,
I think,
yes, no, or maybe. What do you think, Vasant?
I think as Bharat had very clearly mentioned that if you start steroids early, so I think if any patient is very high suspect for COVID-19 and has complaining of, I think, dyspnea or exertion, I think breathlessness or exertion, or is slightly even hypoxic like 92, 93 saturation, I think these are the patients possibly you would like to use steroids, because there is no point in using steroids when the patient is, in severe respiratory distress or severe ARDS and going on the ventilator. So I think there's a role for steroids early, and there has been conflicting issues, but there are a lot of papers in favor. And I know that in US also, it's being tried as in early stages. The moment patient complains of breathless, I think what they do is they do a walk test for a minute, and if the patient desaturates from the baseline by more than even 5%, I think this possibly would be an indication for steroids if you have a very high COVID suspect or a COVID-19 patient positive.
Thanks, Vasant. But still, I would just add on to the fact that all treatments in COVID are all experimental. There will be anti-inflammatory mediators like tocilizumab, steroids, or antivirals, whatever it could be, and then plus a HCQ, plus or minus azithromycin. Everything is experimental. Thanks, Dr. Rajiv, for putting up this excellent line of case steps. And the learning points for the audience as well as me would be that is all fevers are not COVIDs, even in this pandemic situation. You need to keep an open mind in assessing patients and to keep or to rule out other causes of infections or non-infectious etiologies as cause for fever. And then in assessment, probably I think we should get in the habit of measuring oxygen saturation in our outpatient assessment thing, because most of these patients rarely complain of breathlessness, but when you look into the oxygen saturation, that could give us some kind of clue regarding what's happening. And again, a patient who goes into some kind of problems, especially with respiratory distress, getting the ABG in will give us some important pointers towards that. Therapy, I would say that still all experimental. And the point to learn from Kerala is contact tracing, quarantine of those contact tracing, and then swabbing of those contacts by day 5 or day 14, something like that. And that is something that we need to see. And the biggest problem for all of us would be this, to release a patient from the treatment center, let it be a hospital, that is what most of the patients are there. These 2 negative PCRs, which is something that we don't see with any other respiratory viral infection. Let it be influenza, RSV, H1N1, whatever it is. But this is something that we've been told, or this is what is being followed in the rest of the world. So that puts us into a lot of stress on the resources that the country is facing. But that is something that we need to look into it. Probably can we send them home or to send them to some kind of a hotel or quarantine facility? That is something that we need to look into it. Unless otherwise the numbers are going to increase, there will be a lot of pressure on the systems. And these are the learning points that we have. And this negative PCRs is something that we need to work on as a society with multiple collaborative partners. And that is something that we would like to do. And once again, I thank all the viewers for joining this on a Saturday afternoon. And people who miss the live action here can always go into the YouTube, where you'll have to just type in SIDS webinars. You would have access to all the lectures. And another thing is, you could always come into the SIDS website, www.sidsindia.org, and you could have all these lectures being projected there. You can have free access there. And on Monday, we have an exciting session on infection control issues on COVID. Again, it's going to be case-based learning, with Dr. Tanu being the moderator. And then we have 3 panelists from Vellore, Dr. Priscilla, and again, Kerala, co-chief Dr. Anup. And then we have Dr. Ravikant, who's an ID physician from Jaipur. See you all again on Monday. And again, thank Dr. Rajiv for setting up this discussion. Thank once again Dr. Bharat, Dr. Vasant, and Dr. Aravind for sparing the time. Thank you. Bye-bye.
Thank you.